Sir, my mentor and my senior colleague Dr. Abhijit Joshi sir, Umarji sir, Kulkarni sir, and all of you my colleague. So today I am going to discuss on a topic. It is the pre-operative evaluation of cardiac patients who are undergoing non-cardiac surgery. Now, why I chose this topic? Why this topic is really important? Now we see all the surgeons before selecting the patients for surgery, they select the patients very meticulously. They obtain the fitness from the cardiac side, fitness from the physician side, even the PAC from the anesthetist before selecting the patient for surgery. And they take utmost care so that the surgery should be uneventful, and also after the surgery the post-surgical recovery time should be precise and uneventful. But still we can say that as per the data, 1 to 5% patients still suffer from some undue, unwanted, serious complications. Most of them are attributed to cardiac event. Now my PG teacher in Bombay Hospital, the great Dr. Satyavan Sharma, used to say that even the best of the cardiologists in the world can still miss the ischemic heart disease or underlying coronary artery disease in 5 to 10% of cases. So that's why the American Heart Association in 2024 came up with the stepwise approach and the new guidelines so that we may not miss all these patients. Now, what should be our approach for minimizing such a risk and complications? Today I am going to cover up the pre-op evaluation, analyze, and how to identify the clinical risk indices. Similarly, I will lay forth the pre-op cardiac testing which are required, and I will also briefly tell about the updates in 2024 American Heart Association guidelines. Now we see, before keeping the patient for any surgery, the most common cardiac history or the most common underlying comorbidity in the elderly patients is ischemic heart disease or coronary artery disease. The second most likely is the cardiomyopathy or the structural heart disease. Structural heart disease includes cardiomyopathy or any valvular heart diseases. It includes rheumatic valvular heart diseases or senile, degenerative, age-related valvular heart diseases. The third reason may be because of the ischemic heart disease or underlying coronary artery disease and structural cardiomyopathy. Patient can go into the LV dysfunctions or patient can go into the compensated cardiac failures. I am not covering up the congenital heart diseases because we are talking about the surgeries in the elderly population, so most of the patients are not yet documented. Very few congenital heart diseases we can witness in the elderly population. So as we say that even in the meticulously selected patients, the incidence rate is still 1 to 5%, and our challenge is to minimize it further. So what could be the possible perioperative cardiac events? It may be myocardial infarction, it may be type 1 or type 2. So what is type 1 myocardial infarction? So we give fitness to the patients. Patient is all fit, the surgery remains uneventful, but post-op patient develops ST elevations and STEMI or acute MI. It may be because there may be some underlying vulnerable plaque, and it can lead to, because of the surgery-induced stress, it can lead to ruptured plaque, and it can lead to ACS or acute coronary syndrome. Sometimes because of the hemodynamic instability, patient can develop the demand-supply mismatch or type 2 MI. Then some patients are compensated, patients are into the compensated cardiac failure, and they can really become decompensated or uncompensated cardiac failure. The most common patient can develop some arrhythmias. The most common arrhythmia would be atrial fibrillations with hemodynamic stability or sometimes hemodynamic instability also. Then again, some changes in the electrolytes or dyselectrolemia, which can really trigger arrhythmias, sometimes atrial arrhythmias or supraventricular arrhythmias, or sometimes the fatal ventricular arrhythmias also. And of course, sudden cardiac death. So for selecting the patients, it begins with the history. Taking the history is very important. Now, when we get a reference, sometimes we are in a great hurry to give cardiac fitness, but taking the history is a skill, and it is the job and responsibility of physician or cardiologist who give fitness. So he should look for the pre-existing associated cardiac comorbidities like associated vasculopathies or peripheral vascular diseases or stroke, sometimes diabetes mellitus, and diabetes mellitus leading to comorbidities and complications. Patients can have underlying CKD and renal impairment and chronic pulmonary diseases. Then history of previous surgeries, anesthesia course, exercise tolerance, these are the tests which are important. Some patients have history of implantation of some cardiac devices, like patients may have implanted ICD device or pacemaker device. Pacemaker device history is very important because while selecting the cautery, we generally say that if the patient has a implanted pacemaker, then we should use bipolar cautery and avoid the monopolar cautery. Or if we really want to use bipolar cautery, especially in the surgical cases which are above the thorax or head and face or neck surgical cases. This is because the bipolar cautery has got less electrical interference with the underlying pacemaker, or we really want to switch the pacemaker setting with the technical operator. If we really want to use the monopolar cautery, then it should be far away from the distance of the pacemaker, because the electrical current which transfers is to the ground, to the pad so that it may interfere with your inherent pacemaker activity. So this mechanical pacemaker devices history, implanted ICDs and pacemaker is really important. Now we really need to see indicators of disease severity, like patients, are they really having active cardiac symptoms? For example, as we say, the ischemic heart disease patients, all the symptoms are subjective, and we really need to find out. Patients try to compensate, patients try to adjust, patients try to tolerate. But the surgical stress, they may not tolerate, and all these symptoms are unmasked. So we really need to find out the active symptoms, like patients may have the increasing angina or the recent changes in the symptoms. Patient may have some shortness of breath, or patient may have difficulty in sleeping because of the orthopnea or paroxysmal nocturnal dyspnea. So all these symptoms we need to find out. Now, talking about the general examination, we all know, I will not emphasize on that, but the general examination, including the physical condition of a patient, assessment of a vital signs, all these tests are important. And accordingly, we should define that patient is having low cardiac risk, moderate cardiac risk or high cardiac risk. So risk stratification is very important. Now to underline this risk stratification, they have put some indices. This is called as the ASA-PS grading, then Goldman risk indices and revised cardiac risk index. I will quickly cover because this slide is little exhaustive. So talking about the Goldman's cardiac risk indices, these are basically the risk indices, but I need to focus on these three. Number one, patient is having in the active cardiac failure or no. You can find out with the third heart sound or rest JVP. Number two, any previous recent history of acute coronary syndrome or myocardial infarction. Then patient having any arrhythmia, especially ventricular rhythm or sustained supraventricular rhythm. So these are the findings of the risk factor which get higher points. Followed by, of course, elderly age, frailty, then emergency surgeries, they are getting these points. And these risk indices gives total score of 53. Now, if you find that the summation of this risk factor, the scoring system, if 0 to 5, then low surgical risk, 6 to 12, borderline surgical risk, 13 to 25, intermediate surgical risk, and more than 25, of course, high surgical risk. And we require multidisciplinary approach before giving fitness with the patients and patient's relative, before posting this patient for any kind of surgery. Now there is another Destis cardiac risk index, but this is again very exhaustive. I will not go into the further, but again they have got some scoring system for these points, and they have put like 0 to 15 less, 15 to 30 moderate, and more than 30 severe cardiac risk. So you may say, ये तो मुझे इतना याद नहीं आता, मैं नहीं याद कर सकता. So there is another revised cardiac risk index. Simple. How is the type of surgery? This high risk surgery. Patient having any previous ischemic heart disease, heart problem आहे का आहे, brain चा problem आहे का आहे, किडनी प्रॉब्लेम आहे का आहे, डायबिटीस आहे का आहे, आणि काही हार्ट फेल्युअरची हिस्ट्री आहे का. सो दीज आर, इवन इफ यू गेट टू नो दिस 5-6 indices and if we can label them 1 point, and if we get more than 3 points, then we can say that these patients land up in a high risk category zone. So these are the things. Now beyond these cardiac risk indices, क्लिनिकली इव्हॅल्युएशन अँड सब्जेक्टिव्ह इव्हॅल्युएशन, जसे प्रसाद सरांनी सांगितलं होतं की मी काही कुठल्या डाटा गाईडलाईन मधून माझ्या स्लाइड्स बनवल्या नाहीयेत. दिस इज माय क्लिनिकल अप्रोच. सो हिअर ऑल्सो इवन वी कॅन हॅव आर क्लिनिकल अप्रोच फॉर डिसाइडिंग द पेशंट्स इफ दे रिअली फॉल इन टू द low surgical risk, borderline surgical risk or high cardiac risk. So what are the major cardiovascular risks? तर त्याच्यामध्ये असं असतं की रिसेंट इव्हेंट ऑफ ॲक्यूट करोनरी सिंड्रोम. इट मे बी सिंपल अनस्टेबल अंजायना और नॉन एसटी एलिवेशन एमआय, और इट मे बी STEMI, acute ST elevation MI. Now patient having a persistent decompensated cardiac failures, like if patient is getting hospitalized more than 3 times in a 1 year, or patient are getting really high persistent levels of NT-proBNP levels or high levels of troponin I associated some renal dysfunction, like creat levels remain always like 1.5 to 2.5, even if they are non-oliguric. Urine output is good, but they have underlying CKD, they have underlying LV dysfunctions. EF is like 35%, and patients remain in the compensated heart failure, but sometimes they get decompensated and requires 3 or more than 3 hospitalizations. Then these patients really fall into the major surgical risk. Then patients have witnessed certain arrhythmias, especially either it is tachyarrhythmia or bradyarrhythmia. Tachyarrhythmia, they are the arrhythmias which produce hemodynamic instability, like ventricular arrhythmias, or bradyarrhythmia, heart block. So these are the major surgical risks. Then intermediate risk, these are all intermediate risks, that patients having low events of cardiac failure, renal insufficiency, and minor risk, advanced stages, some abnormalities in the ECG and here and there. So here we can assess and put patients into the categories of a minor, major and intermediate risk. Now in 2024, American Heart Association has put forth some updates. So they have focused on the stepwise approach. की directly fitness द्यायचा नाही, go for the stepwise approach. So they have put some steps, step 1 to step 6, how to categorize and give fitness before the surgery. So this avoids any emergency revascularization or even if undue or unnecessary prophylactic coronary revascularization for these patients, and you can straightforward select the patients or deselect the patients. So they have put forth some steps. Here I will go with some steps. Now suppose patient is requiring some surgery, and we may or may not know that patient is having ischemic heart disease or underlying coronary artery disease. So we go for the clinical history and checkup of this patient, and if the surgery is imminent and non-avoidable, emergency surgery, then explain to the patient and post for the surgery and explain about the high risk mortality. But if the surgery is not emergency, then proceed for the step 2. So what is step 2? Evaluate. If patient is having angina, then it is chronic coronary syndrome or acute coronary syndrome. If it is acute coronary syndrome, then again evaluate for acute coronary syndrome, treat the patient, postpone the surgery because it is elective surgery. If patient is not having acute coronary syndrome, then proceed for the step 3. Now, if patient is not having ACS, patient is having coronary artery disease or chronic coronary syndrome, then evaluate. How to evaluate? Go for the perioperative risk factors of MACE events based on the clinical risk factors and surgical risk factor. Yeah, just 5 minutes. So in the step 3, how to calculate the MACE events? So we go for the surgical risk calculator, and based on the surgical risk calculator, we define that patient is having low risk probability or high risk probability. Now if patient is having low risk probability, give fitness and go for the surgery. If patient is having high MACE events and high risk probability, then evaluate functional capacity or the METs, metabolic equivalence. Now if patient is having intermediate or high METs, then again no intervention, no further workup is required, we can post for the surgery. But if patient is having poor METs, then again we require evaluation. Either we have to go for the stress test or dobutamine stress echo, and if these tests are normal, then again we get a confidence to post this patient for surgery. If the patient cannot perform, or if patient has poor functional capacity, then we may not give fitness and we require coronary angiography or CT calcium or CT coronary angiography and further evaluation. And if the surgery is really not imminent, then we need to treat with the coronary revascularization, and after few months down the line we can post for the surgery. If the surgery is really not important, for example, surgery is important, but as per the patient's life expectancy and other things, we may require some palliation and effective therapies. Now I talked about the functional capacity. The functional capacity is calculated based on the METs, that is metabolic equivalent. What it defines? It quantifies the functional capacity by measuring the energy expenditure relative to the rest, where one MET is equivalent to resting oxygen use. For example, जे आपण बसल्या बसल्या आपण ऑक्सिजन कंझम्पशन करतोय, and when we are active, so how much times we can utilize the oxygen during being active. So that is what we calculate METs or metabolic equivalent. So patient who have excellent physical capacity can obtain 10 METs. Patient who has borderline physical capacity can obtain around 4 METs. सो आपण फॉर एक्झाम्पल एक सिम्पल हा चार्ट आहे, ह्याच्यामध्ये असं दिसतं की इफ वी कॅन वी आर पॉसिबल फॉर हॅव्हिंग सेल्फ केअर, स्वतःची कामं स्वतः करू शकतो, स्वतःची काळजी स्वतः घेऊ शकतो, देन इट इज इक्वल टू 1 METs. आपण घरामध्ये स्वतःची काळजी घेतोय, पण आपण आजूबाजूची आपल्या कलिगची पण काळजी घेतोय, फॅमिली मेंबर्सची काळजी घेतोय, देन इट इज अराउंड 4 METs. अँड इफ वी आर रिअली फिजिकली ऍक्टिव्ह, जॉगिंग करू शकतो, एरोबिक एक्सरसाइजेस करू शकतो, देन इट इज अराउंड 10 METs. सो हा एक सिम्पल चार्ट आहे. आय विल स्किप दिस. One slide which I want to focus on is what is the importance of type of surgery. Now we know that even the type of surgery is really important. So it is the mixture. On one side there is a patient profile with mild, moderate and heavy cardiac risk, and on one side it is the type of surgery. For example, suppose a patient is having high cardiac risk but has to undergo some minor surgeries, like for example simple endoscopy, OGD or cataract surgery. We may give fitness. But patient is having low cardiac risk but has to undergo very high surgeries, like patient has to undergo major operations, or patient has to undergo some aortic surgeries, or patient has to undergo peripheral vascular surgeries. So these are really high cardiac risk. Then intermediate मध्ये येतात तुमचे पेरिफेरल व्हॅस्क्युलर सर्जरीज, लाईक कॅरोटिड एंडाट्रेक्टोमीज, हेड अँड नेक सर्जरीज, orthopedic surgeries, prostate surgeries. So these all fall into the intermediate risk. So how to deal with this? Suppose patient undergoes angioplasty. Now patient will be on blood thinners, strong blood thinners, and 2 blood thinners, which are generally continued up to 1 year. And if you find that patient has recently undergone angioplasty and now he requires surgery, so we need to find out, is surgery really emergency or elective? If patient surgery is very elective, then we can wait and ask to patient for close follow-up and do the surgery after 1 year. If surgery is not elective and if surgery is emergency, then we need to assess the bleeding risk, and then we need to consider the bleeding risk and go for the surgery. If the surgery is intermediate, as I said, there are some intermediate kind of surgeries, then we need to consider some bleeding risk, and we may post the patient after 3 months of angioplasty, and we may withhold 1 blood thinner. Now, so we have to address the thrombotic events like strain thrombosis versus bleeding risk. And if the surgeon is very confident enough to handle the bleeding risk during the surgery, we may post these patients after 3 months of angioplasty. Now, but sometimes this is one, just last 2 slides, sir. So we may find certain undue time that patient may get certain emergency time that patient really require. We cannot postpone the surgery. For example, some abdominal surgeries, for example perforated peptic ulcers, acute abdomen, or obstructed hernia, strangulated hernia, or acute cholecystitis, in which surgery is imminent, we cannot postpone. And we have cases that patient has just undergone surgery like 15-20 days back, and surgery is imminent. So what to do? So as we said that एक बार antiplatelet चालू हो जाता है, once we take the antiplatelet, its half life is like 1.5 to 2 days, so its wash out time like 5 to 7 days. So we cannot stop antiplatelet because patient has undergone angioplasty. So what to do? So we need antiplatelet which has got shortest half life. So there is another antiplatelet called as a cangrelor. So we use this antiplatelet as a bridging regimen in which even if the patient is recently undergone angioplasty, we may consider him for the emergency surgery. So what we do, we just stop the antiplatelets, start the patient on IV cangrelor 3 days prior to the surgery. As I told you that this antiplatelet has got half-life of 3 to 6 minutes, so we have to give it with a continuous infusion dose for 3 to 4 days until the time of surgery. Now before 6 hours prior to surgery, just stop cangrelor, give one sort of low molecular weight heparin, post the patient for surgery, do the surgery, post surgery, see for the bleeding tendencies. If the bleeding tendencies are very minimal, then you may start to the oral antiplatelets. If the bleeding risks are little higher side, then again switch back to the IV cangrelor, and when the bleeding risk goes down, shift the patient on oral antiplatelet. This is because, as I said, the oral antiplatelet has got the longer duration of action, like 4 to 5 days, and we may not stop it because the patient has just undergone angioplasty, and if you stop the antiplatelet, then there is a chance of stent thrombosis. So for this, we need to consider bridging regimen, that is the IV cangrelor. Now another last slide, another condition in which patient has undergone wall replacement surgeries. Maybe it is a aortic wall or it is a mitral wall, and we need to post this patient for surgery, and patient is on a warfarin or oral anticoagulation. Now again here we need to stop the warfarin. Now what to do? We require the patient's INR well below 2 for the surgeries. Now if we find that the patient's surgery, if the surgeon tells that I don't want the bleeding chance, then we need INR up to 1.5. If the bleeding risk is mild or moderate, then even surgeon allows the INR to be kept around 2. So in cases of aortic wall or mitral wall surgeries, we can just discontinue the warfarin and allow the INR to fall. And post surgery, in cases of aortic wall, we may again start the we can wait, because these are the high pressure jet walls, and we can wait and allow the INR to build up again naturally, and we can start warfarin. If the patient is having mitral wall replacement, or if patient has having metallic wall, then we really need to start on the injection heparin or low molecular weight heparin post surgery, and allow the bleeding risk to go down, and once the INR reaches 2, we can start oral anticoagulation. Thank you.